It's really great to be here. How's everybody feeling? All right. Yeah, good morning. Friday, I believe. I've never looked forward to weekends more than since I came to the Department of Health. Although I gotta say, we spend a lot of time on the weekends trying to catch up and do things. One of the things that concerns me about these large meetings is that we end up being kind of talking heads, and generally we don't want that. That's actually antithetical to the whole purpose. And this is what I've been calling December 19 2.0. Because it was December 19th when we met at the endowment, we talked about how we wanted to evolve from the prior stakeholder engagement process to something that's much, much more robust, where we're getting input from more people, where we ourselves have a better system internally to integrate the information and create an iterative process that really drives and guides the department. And one of the ways I like to think about that is that on a regular basis, we're breathing in the information and we're breathing it out. We're doing that together as a way for us to kind of develop the connectivity that we need in our county, Hadley. It's not easy, and I'm not going to say it's going incredibly well all the time. I like to think, and when we started on this, I thought, oh, well, this is a stakeholder process, and unlike the programs, which take sometimes years to push out, we can get the stakeholder process thing down. Well, it's just as complicated, if not more complicated, and it's critical, it's core. And I hope people are beginning to understand that we recognize its core and we're committed over the long haul to developing the best stakeholder engagement process we can. And I think one that will lead the state. And I talk a lot to the other directors across the state about what they do. And one of the things that's quite different is literally just the size of this jurisdiction. And one of the things that compelled us to move towards a new and more robust approach is the fact that we got, I don't know how many counties in this county. We got a lot of counties. We got big counties, we got medium counties, we got small, and we got frontier counties. Those are the types of counties across the state. We have the most dense urban environments, and we have the most rural. So that's not an easy task. But we're in it, and we're committed, and we're going to grind this out together. On the 19th, and I think obviously over time before that, we've collected an unbelievable amount of information. And our teams have sifted through the information and tried to categorize the information into digestible sets of data that we as a department can leverage to guide our decision making. And this has been going on, as you all know, many of you all know, a lot longer than I've been here. But I gotta tell you, it was very encouraging to me to see the categories of information, the types of recommendations that were coming in, and the direction of the department. And I don't want to steal other folks' thunder here, meaning, because I think that we had individuals presenting on the different categories. Would it be totally inappropriate for me to go through the list and just highlight some things? I do?
Yeah, no, absolutely.
Okay. And then we're having a little conversation here. As far as the things such as the fact that we now have Gov delivering to 9,500 recipients. Did you talk about that? 10,000. So that means that the stuff that we're doing and that we're posting is getting pushed out to 10,000 people across Los Angeles County, which is a significant bump. And I think that that's just going to grow. The more available we can make the information, the more people that know about it, the more connected we become. have you talked about, or are you going to talk about, just to reframe the idea of our overall approach with the SACs and the other sort of cultural communities and the coalitions and the groups and the monthly meetings? Is that something you're going to cover, or should I mention it?
You can mention it, and I'll be covering it later.
Okay. I guess I'll just say at a high level, and you've probably heard this before, and we're going to keep saying it until it makes sense to all of us. And if it doesn't make sense, we want to know, and we will reframe. But the idea really is to recognize that the service areas are a platform for us to look at geography, and the SACs are a way for us to empower stakeholder engagement and voice. And that voice comes in, and then the information goes out. And we're trying to invest heavily in the service areas. One of the things that I've wanted for well over a year is to get transportation so people can come, and also to get video. And we're close. We're close. And you know, like rideshare. You know what I mean? You're going to come to a SAC and you don't have a car, or you can't get there, or whatever. Okay, if you're coming in a meaningful way, we ought to be able to provide that transportation. You know, with Uber or Lyft or whatever. We're trying to get there. That's real. That's actually saying to a consumer or a family member or any kind of stakeholder or advocate or frankly business member, come on in. I don't know where we are with the telly. You know, and I'm hoping we'll get there. Antelope Valley, as an example. You know, how do you travel around the north? It's a big place. I mean, I go up there. Santa Clarita, there's many, many places. The point would be, we want to get people to come in. The other sort of cultural communities, the cultures around Los Angeles County are plentiful and beautiful. And how do we overlay that on the fact that there are geographies? We're trying to figure that out, and we're focusing on it. How do we deal with the fact that in each service area, for example, there's a veteran seat? And we want to know in each service area what's going on with the veterans, but we also would like to have a voice for all of the service areas around the veteran as one example of a seat. It's a seat that's mandated by the state, but it's also a seat that we care about. And we have heard you that we need to have monthly meetings to kind of make sure that we're consolidating all the information and moving it back and forth in between the larger quarterly summit type meetings, and we're having one at the end of the month, which is the annual update. So in theory, if you can imagine, and I'm sorry, Amy, you probably can talk about this again, I can't help it. If there's a veteran, if there are 8 veterans on each, if there's 8 veterans who are representing the veteran voice across the service areas, what we're saying is that their voice can be consolidated if each of them is talking about what the needs in their community, in their service area, and then bringing it in, representing that on a monthly basis and grinding it out. It's not about one particular vet, it's about the veteran voice. And is that something that changes every year or every 2 years? Do you elect a person that represents for the 8? We're asking you to help us figure that out. I do have a long list of the different categories. We have basically the groups of the categories of data fall into clinical, what we're saying is prevention, administrative, and communications, stakeholder engagement categories. And we're going to have leads from each of those areas coming up here to talk about it. And I am a little bit fearful that this is going to be a talking head experience, but you know, we're actually leveraging it as an opportunity to give you feedback. You know, and it took about, how long did it take? About a month to grind, or maybe even 6 weeks to get through everything that came in on the 19th of December. But you know, that's what it takes. And what I want to tell you is that the quarterly summits, we have historically, and I think it's true across the state, had an annual update or a 3-year plan every 3 years. And that's a great thing, because the idea is that it's a culmination of work that's happened over the whole year. But what we're saying now is that we don't just have to do that once. That if we have quarterly all-day summits, and I'm going to do everything I can to be there. And although I got to tell you, I get ripped in different directions. I got to go see Supervisor Sleaze at noon, so I'm probably going to have to leave 20 minutes early to get there, and I'll probably be 5 minutes late. But we're committed to say every quarter we're going to have something akin to the annual update. And it's not just a practice for the annual update, it's to vet the overall plan of the department and get input about what are the overall plans, what's the overall progress, what makes sense, what doesn't make sense as a larger community known as Los Angeles County. When I look down this list, and I'm just going to run through real quick, building equity for underserved cultural communities, expanding full service partnerships, increasing teletherapy, expanding mental health services for inmates at the county jails, diagnoses for mental illnesses, clarifying, redefining, permanent supportive housing at county hospitals and in vacant areas of Los Angeles County, maintenance of 5150 hospitalizations, easier processing of involuntary orals, increasing support for PMRT, increasing access to cognitive behavioral therapy, focus on gaps for veterans, access for veterans. Every one of these things that I just said to you are resounding messages in your feedback to us, and every one of those things we're going after. Prevention. Expanding health neighborhood programs to be inclusive. Well, Debbie's going to come up here. Debbie, you're here. I think I saw you. Hi. Debbie just finished doing an amazing job with the state on MHSA, and I want to thank you for that, Debbie, publicly. I think you all are aware of Innovations 2. Innovations 2 is a massive investment across the county to build capacity in our communities and our neighborhoods. I was just at USC at the Wellness Center, and I was talking to them about all the stuff that we want to do, and they're like, oh yeah, well guess what? We got some money through Innovations 2, and we're going to be using it to do A, B, C, D. You're going to hear about these things you all know about, and many of you, I hope, are getting resource funded to be involved. And one of the things that we care about very, very much in a system that's almost impossible to navigate, even if you're at the top of your game, is navigation of the systems. So if you build communities properly, neighborhoods properly, people know what's going on. Stigma's not as big of a deal. And you've got agents, ombudsmen, navigators, concierge, helping you navigate these systems. That's a big deal. So we're investing in that. Staff at community colleges. Yes, we're doing it. Decreasing language and literacy barriers. We're doing that. We're in the process through our cultural competency unit of trying to get multiple translations of our website. We're trying to make sure that all of our materials are multilingual. We're trying to make sure that the training that we have, not just in the Department of Mental Health, but in the other health departments, are culturally and linguistically competent. We actually, as a department, are taking that on as the lead, and we're funding it. Educating people about co-occurring disorders. We're actually creating a unit and hiring a lead that's an expert in comorbid disorders to come and help us grow that. And one of the biggest problems there is that at the state, it's siloed. The funding doesn't come down for us to use, and you all know this. If you have an integrated problem, you can't come and get integrated services on the same day, in the same facility. And we're going after that legislatively. School-run mental health and wellness, I would say well-being programs. Yes, look in the newspaper. We're going after that. We need help, how they roll out, and because of that, we're having stakeholder groups. There were a number of people who got together in an intensive way with LACO, with LAUSD, to find out what is it that you all recommend, what are the needs at the schools. And then we're using that to build our plans, and we're using that to determine how we're going to deploy our resources not just in LAUSD, but across the schools of Los Angeles County in a way that is targeting the most vulnerable and disenfranchised populations. Updating mental health education curriculum. We're trying to build into, at the state level, actually legislation that will mandate mental health curriculum in the schools. And then we're trying to develop internship programs for the kids that will pay, so that kids can help us in ways that no clinician's ever going to help us, because kids have street cred in their own school. And maybe they then become kind of inspired about the work and want to become a part of our workforce. That way, we're bringing people to help lift their own communities to be a part of the solutions, which, by the way, is probably the most important thing to transform our culture. That would be my opinion. More friendly environments. I'm moving over here to administrative stuff. Sorry, Edgar. More friendly environments at the DMH facilities. You know, I say this all the time. We've got clinics, and they're lovely clinics, and they're great clinics, and they take it forever to build. But we actually want mental health centers. We want ecosystems of resource that are holistic. It's not just about going to see your clinician. That's not the recipe for well-being. You need to be able to go to places when you are lonely and you want to connect with other people. Respite. If you're not doing well, does it mean you have to go to an urgent care center or to an emergency department or be brought there? No. How can we figure that out? You know, in other parts of the world, and in Trieste, which we talk about a lot here, they actually have crisis beds that people can use. And they're not all full because they have a system to support people in a way that we don't. And how are we engaging the rest of the community? You have to create welcoming environments. That's a big part of it. We invested, I don't know, $5-6 million to be used to help build up our facilities. We need to think about that across the spectrum, not just for our directly operated or our contracted clinics. And if we don't do that, who wants to come? We need to invite people. It's a part of the culture as a environment. Simplifying paperwork, don't even get me started on that one. Because my blood pressure is already a little bit high. Just thinking about all of this stuff. And I mean that in an exciting way, an excited way. But this is the top priority of the state for all mental health directives, behavioral health directives in California, which is payment reform. Give us the money and facilitate our success in the trench to take care of people, because we don't want to take care of auditors. We're done taking care of auditors and charts. People. And all the auditors and all the money spent on auditors ought to be spent on people who can come and help us lift and facilitate our work. Pay it forward. Expanding hours. Yes, we want to expand hours. We want to do what we want to meet people's needs. And if the needs are coming early, coming late, coming on weekends, we want to get there. That's not an easy thing to do in a large bureaucracy. It's a lot more difficult than I had anticipated, because I started to drive that, and a not unusual occurrence, I got kicked in the front and the back of the head by different stakeholder groups about why I can't do that. But we're going to figure out how to do it. It involves things like overtime. It involves things very, I think, important, negotiations with the unions. It involves a liability for the use of the space. All of these things that don't occur to you when you say, well, that's a great idea. Okay, well, converting on that idea, operationalizing that idea is extremely complicated. And when I hear things like we don't have enough space, I'm saying that's because we don't have enough hours to use the space that we got. And if you increase the number of hours that you use the space that you got, you get more square footage for people. improving the areas surrounding facilities and again the environments. I look at so many opportunities for us to engage our clients in the rebuild and the re-engineering of the work that we do, whether it's through navigation, whether it's through welcoming environments. And that's one of the things that we're looking to do. And I don't know if Karis will be here, but Karis Myrick, who is our peer chief, we're proud to say, is very, very focused on creating the strategy and the career ladder to bring in our clients to be a part of the solution. And we have to do that. That again is a part of our culture, it's a part of the new culture. The Peer Resource Center is one peer resource center. It's a bit of a flag in the ground that we're planting to make a statement about heart and heart forward in that building, which is a new place. But we want that everywhere. So we don't just want that at headquarters, we want that kind of resource around the county. And the number of things that can be done there is huge. And I'm suggesting that that's one, and that we want that kind of resource all over the county. Yes, absolutely. In fact, you can't have what I was calling a mental health center without it. I don't know how much time I got. Maybe you're probably getting ready to give me the.
You might want to take a few questions.
Yes, I would like to do that. There's a long list here, and I guess what I'm saying is it has not been easy, and a lot of the things that come back to us are difficult to digest. But when we crank through the information we've got, and we look at the categories of requests and guidance and complaints, the department is actually very much on target, and because we don't want to be tone deaf. We want to listen and we want to respond. Yes.
So we've got time for about 3 questions for Dr. Sherin, and all of the things he was just going over, as I mentioned earlier, we have staff here, and we're not going to be up here as talking heads through this event, but everyone knows that they've got roughly 15 to 20 minutes to talk about what we're doing, the rest of the time devoted to listening to your voices. So if you're on staff and you have a role, just remember, I'll give you the hook in 15 minutes so that you can get the voices from the people reacting to what we're saying. So Destiny, you have one person with a question?
Hi, Dr. Sherin. Cynthia Perez from Service Area 1, Antelope Valley. A couple questions. First, can we make sure that Karis comes and does a update maybe on the next meeting? That would be wonderful.
I'll just mention Karis was planning to be at this meeting. She had a training. That's the reason she's not here, but we absolutely will.
Wonderful. And then, so I'm the program manager for the Antelope Valley's only Peer Run Center. I encourage the department to look into having grassroots, nonprofit, contracted organizations run these peer run centers. Some people, I'm going to be honest with you, they don't want the department running their peer run centers. They just don't. They feel that it's their clinic. And so whenever you do it with your contracted agencies, it sometimes works better. So I would like you to look into that. And if you need any help or anything like that, anyone's welcome to come up to the Antelope Valley and visit our peer run center.
Yeah, 2 comments. First of all, I'm by no means saying that peer run centers will be directly operated only. I didn't say that. I'm saying that you can't have, just let me finish. You can't have a mental health center without a peer resource. So the mental health centers are all of the clinics around the county, including contracted. The fact that many clients don't want to come to directly operated governmental clinics, I get it. And what I would say to you is, that's the case now. And we look to change that as well. And we may never do that for certain people, but as we change the culture of the work that we do, we achieve things like payment reform, we figure out how to invest in ecosystems that include not just clinical care, but support for human beings. Those clinics, including even the directly operating clinics, I believe, will have the types of peer resource center that we need, and we would look to you and everybody else around the county to get that expertise about how it's done best.
Hi, my name is Tiffany Duvernay. I'm a regional leader, Access Ambassador for Access California. And I'm also a consumer. I receive my services over at West Central in service area 6 off of Stocker and Crenshaw. I wanted to paint a picture for you about security and make requests. So if I go to a meeting over at the Hall of Administration where the board of supervisors are, you know, when I walk through the front door, there's two, I believe, sheriffs kind of sitting a little in the distance in the corner, right in the front. But you walk through or next to, you know, the security apparatus, you just walk through. And if you don't beat, you keep on going. You can say hi to security if you want and keep on going. There's nothing intrusive about it. But when I go into different clinics, it's more intrusive. So for example, there is a clinic where you can like put your bag on the, I forgot what it's called. But the thing that's spinning, yeah, the x-ray machine that goes through, you walk through, and you go. That's less intrusive. But I will say that at West Central, it's extremely intrusive, and there have been many complaints about the process. You go in, you drop your belongings on the table, and if you have a purse or a wallet, there's someone who actually goes through it. Opens zippers, peeks in pockets. For me, that's intrusive. And then you turn around front and back, and you're wanted. And one time I was wanted, the one hit my breast, and I didn't appreciate it. That was a little bit too close. It happened to be a woman that did it, so I'm pretty sure I had less of a reaction than if it was a man that did it. But there have been several complaints. Something is being done about it. So I know that Carlotta had the different type of security system put in there, but last week, even for our SAC 6 meetings, we're not just allowed to walk in, we have to go through the same security process. And this machine was too sensitive. So even though it's there, it's picking up on like what's in people's wallet, not just like a knife or a gun, but it's not fine-tuned enough where you can just, you know, walk in. And so I'm sure something's being done about it, but as of a week ago, it was still intrusive. But I just like that to be looked at across LA County. What is the person's experience just to be able to walk into a clinic and that it be less intrusive and more welcoming, because that's the first point of contact when you walk in.
Yeah, I think this is a big issue. It's an important one, and I'm not going to tell you there's an easy answer, because if you poll 100 people, you're going to get a public safety response and you're going to get a public health response. So this is not easy. It's not, and there are people that work in the clinics who don't feel safe. And you're like, I'm not coming to work, and I'm gonna protest. And the unions have very, I think, legitimate concerns. So it's not a simple solution. And what I would suggest, as with everything, this has to be really resolved at the local level. And when the local level determines what's the thing it wants to do, the department has the opportunity to try to support that. I always tend to be on the public health side of things. And I think that you have a less dangerous environment, the less, the more welcoming the environment. And that if you have, in my view, if we do things right, we won't have to have so many locked environments, because people will actually want to come in and get help. I went to USC for a meeting 2 days ago, and I went through and I beeped, and I took off my boots, and I kept beeping, and I'm getting wanded, and I wasn't going in from a compare, I was just trying to go in and have a meeting with the CEO, I was like, what's the deal here, guys? But bad things happen, and when bad things happen, there's always a reaction. And then there's bad press, and then there's lawsuits. And on the other hand, it's a deterrent. I tell you what I really don't like is when you have not just the metal detectors, but you have like 3 to 5 security guards sitting around And then you got these everywhere posted, stop, big, no weapons, no, okay, really? There are many ways that we can, I think, much more effectively attend to the public health and public safety needs of our communities and our staff. And we're trying to do that. In fact, we have a group of people, and the discipline chiefs are very involved in this, looking at the nature of the buildings and the environment and our process to go after this is one of those issues. And I wish it could happen faster. I mean, when I go to the clinics, I ask the program heads, why is the big message here, no, no, no? And why is it, why are these all these like circles with like a thing? I have a big slide. I don't have many slides, but one of my slides is a big circle, red one, with a big line. And you know what it says in the middle? It says no. So no, no. Okay, say yes.
Okay, here's my next question. Thank you. Thank you, Dr. Sherin, for all that you're doing to help DNH. Very much appreciated. Families who are struggling with loved ones with severe mental illness live in the interface, a very small, narrow space between the mental health illness, the illness of their loved one, and the mental health system. And they see everything. They are right in the middle of it, and for years. And I'm sorry to say, and the things that we have experienced with DNH, as well as what you have said, we don't see very much there for severe mental illness, because our loved ones do not want to go to wellness centers. They do not want to seek treatment. They don't want to accept that they are ill, and this can go on for decades. So I wanted to ask you if you're going to have a discipline chief for families, because a lot of them are in serious crisis. They need support themselves. They are basically handling conservatorships, trying to find places for the loved ones. And DNH seems to be focusing entirely on those who are able and willing to accept treatment. I'm sorry to say. The other thing I wanted to mention is that you talked about auditors. I'm not quite sure which auditors you're referring to, but many of the services that we receive are poor, inadequate. And I don't know if there's anybody doing any auditing or oversight, because they need to be held accountable for terrible things that are done to our loved ones. I can go through stories and tell you, because I'm also in advocacy and I've been helping and supporting families for a long time. So I see, not only just from my own experience, but what they experience. I just wondered if you could talk about the family chief, discipline chief, as well as oversight on some of these facilities that are contracted. Thank you.
Well, those are deep, insightful, important comments. And I got 10 different things I want to say. I'm not sure where to start. Get to you. First of all, we have to embrace the concept of taking care of households, not people. Because if you can't take care of the household, it doesn't matter. It's not going to work. I did meet with all of the representatives of all the counties. I lost track of time, maybe Wednesday. And we talked about this topic. And what one of the things we look at, what is the mental health? What is a system of care? And one of the things that you need for a system of care is not just services, but you need living environments, and you need all the interstitial activities that support, which is not clinical. It's not only clinical. And what I've asked Nandi, and I would ask all of you to think about is, for those families that have been broken up, and the bridges that have been burned by mental illness and by behavioral health issues, what would you need? What would it take for us to develop a program that allows individuals to stay at home? How can we resource that? And what are families willing to do as partners to make their home the home? When I don't know how many of you were here and got to meet with people from Italy, actually not just from Italy, but from Italy, from Scotland, from England. And they asked us about our interactions with families, and they were like, what are you doing? And what I said is, well, we're trying to get to where you go, because families are assets in the solution for people with serious mental illness. And in fact, some might argue they're as important or more important than any. And we have lost sight of that. It's not just LA County, it's USA, and it's most of the world. But what you're saying is really, really important. And I was dead serious with them to say, what is that program? If you think about, I'm always trying to figure out how we solve the issue of homelessness for serious mentally ill who have become disenfranchised and isolated from the universe, from their communities, from their families. And it's like, oh, well, we can build permanent supportive housing, get $250,000 per unit, it takes 3 to 5 years to build it. And then if you're isolated, many people fall out, even if you provide them tons of support services and clinical services. How can we leverage the families, the homes of Los Angeles County to keep people with their family or just their household? And that's a challenge to the community. I don't know what that looks like. You know a lot better than anyone. And many people who have had the same challenges would know what that looks like. Auditing. What I'm saying is that our staff, who are beautiful, committed, mission-oriented people, can't actually lead with their heart because they're taking care of bureaucratic
bullshit.
I'm not going to in public use inappropriate language.
Come on.
Okay, so what that results in is what looks like from the outside is poor care and people that don't care. And the reason is because they have to care about the auditor from the state and the Fed. And we owe about $50 million in payback, as well as every other county in the state, because of an audit. And the audit is bean counting people who come down and say, how many of these 55 boxes were checked in every chart? Oh, well, you only got 48, and you needed 49. So we're not going to allow that payment. And I say to them, you know what? Some of these 47s and 36s, these are the people who are actually spending their time taking care of another human being and not your chart. Now, the biggest issue, in my opinion, that you're bringing up is one that I want to go after, and I said it the day I got here, because I got selected by the board to try to move things, and that is, what's our core population? And our core population is to be a safety net for the most severely mentally ill people that are suffering from the worst illness in Los Angeles County that don't have access to other means. And there are many, many reasons why we have to, of course, adjust. And a part of it is this issue you bring up of engagement. We have to set up systems that will be attractive to people who are suffering from the most challenging conditions. And I would ask you all to help us understand what that looks like and how we can create it. What I'm saying is ecosystems of care, mental health centers, easy access, not coming in just because you need to see a clinician, but because you need to belong and you need a purpose. We ought to have thriving peer enterprise across this county. And we're trying to drive that because that's something that appeals to every human being.
Okay, Dr.
Those
Sherin.
who are not aware of their illness don't want to have anything to do with it.
I'm very well aware of that, and it's called insight in the business. And insight is a core feature of mental illness across the board. And working with families and working with a system of care that presents opportunities, not just services, which is why I'm talking about mental health center, which is why I'm talking about engaging the community so that people have a place so they belong and they have a mission so they have purpose, is a huge part of the solution. If we have things that are appealing to do at our mental health centers, not our clinics, we will attract more people with more severe needs.
They need occupational, vocational.
Well, that's what I'm talking about. Am I not talking about that? I mean, I'm asking you. That's what I'm asking you. Do you not hear that? That's what I'm saying?
Well, they need mentoring to help them get jobs.
Yes. And so one of the things that we don't have enough of, occupational therapy. Occupational therapy doesn't mean get someone an occupation, i.e. a job. It means find them something to do that is purposeful and useful and satisfying. Now, for individuals who need support in their employment, there's supported employment programs. We don't have nearly enough of that. But when I say purpose and belonging, I'm talking about exactly what you're saying, which is to draw people in for opportunities, not just services and treatment. So I hear you. And this is a major culture shift. It's a major reinvestment strategy.
All right, Dr. Sherin. Okay.
We've had a couple hands that have been up right here.
Well, I just also want to make sure we stay on track because we have other leadership coming up to talk about a lot of these things and the things you were talking about, Dr. Sherin, before. We want to have that engagement. So I think for this segment, we're going to have one more question. Then we're going to continue questions as each of the leaders come up, and Dr. Sherin will be here as well. Go ahead, Dexter. Go ahead.
Hi, I'm Richard Fleming, a mental health advocate for the Van Nuys Climate Center. My question is how will these peer resource centers prepare consumers to participate in the mental health planning process?
I'm going to put that right back on you. Get them there. Advocate for them. We're wide open. I'm telling you that we're going to be providing Uber to anybody that wants to come to one. I'm telling you we're going to provide video screens for people to participate. And I need the community, we all need the community as a collective to participate. So I'm not going to come to you and solve that problem. You're going to come to us and solve that problem by saying, listen, there's a great platform. You have an opportunity to participate. The Department of Mental Health is providing a platform for us. Please be a part of it.
Okay. So how will we access those resources?
We will be getting information out about that very soon.
Okay.
And you can connect again through the website. We'll be pushing things out. Thank you very much.
That's a great question. I mean, what I just said to you before is it's taken over a year to get rideshare, but we're almost there.
We are almost there, exactly. Debbie, would you like to come up now?